Hi everyone, I'm Phoebe and I'm one of the volunteers for the Cardiff Support Group. So tonight we are joined by Dr. Katy Vincent, who is an Associate Professor, Senior Pain Fellow and Honorary Consultant Gynaecologist at the University of Oxford. Katy is going to be talking to us about pain and also some self-management strategies, which I'm sure would be useful for everyone really. She'll also be sharing a little bit of data that she's gathered through the COVID global study at the University of Oxford. So a number of you have already sent in some questions. So I'll be asking Katy those questions on your behalf. So yeah, I'll just pass over to you, Katy. Thank you for joining us.
Sorry, first step, unmute myself. Thank you very much for asking me to do this today. So I'm just going to try to share my screen. Hopefully, can you see my screen now?
Yeah, I can.
Yeah, perfect. Okay, so as Phoebe just said, I'm going to talk about pain management during COVID particularly, because I think that's really relevant right now. So the outline of what I'll talk about today is why is COVID-19 a challenge for people with endometriosis? A little bit about what we think causes pain in association with endometriosis, and then spend some time thinking about how you can manage endometriosis associated pain. And obviously that will have a focus on COVID-19, but hopefully lots of the things that we talk about now will be useful going forwards as well. So why is COVID-19 a challenge? Well, it's a challenge for everybody, isn't it? There's a whole lot of health anxiety going on. We're worried about catching COVID. We're worried about family members catching COVID or friends. If we have anything underlying, we're even more worried about it. It's added restrictions to our normal lives, particularly in the first lockdown. There was a real change in shopping habits, food availability. People weren't able to go outside, so a reduced ability to exercise. And particularly for those who weren't working at all, there was a real sense of social isolation. And there's been increased stress throughout the last 6 months. People have concerns about jobs, businesses, financial worries, and having to homeschool young children has also added an extra dimension. And for those who don't have a happy home environment, that's also added some really significant fear and stress. And this is a study that was published in the Lancet Psychiatry a few months ago, looking at mental health across the whole population. So this is an ongoing survey that checks in on people on a fairly regular basis. And they compared their data from 2018-19 to April 2020, so really very early in the pandemic, and saw that there was a real significant increase in mental distress. So about 20% of the population in 2018-19, up to 27% a month into lockdown. And mental health was worst in young people, 18 to 24-year-olds, and then 25 to 34-year-olds, in those with young children and with women. And I'm sure that probably overlaps lots of you listening to this today. And why do we think the pandemic might have a greater impact on those with a chronic condition? Well, obviously, there's an even more of a health anxiety if you're worried about whether your condition or some of the treatments that you're using increase your risk. It might make it difficult for you to access normal treatments or worry about impact on planned treatments. We know that some of the symptoms are quite difficult to manage at home, but for other people, symptoms of their condition might be hard when they're out and about if facilities are closed. So people with incontinence, people with stoma bags, those kind of conditions will have found it really challenging when there were no public toilets anywhere. And obviously for anyone who has an associated mental health condition, that's at risk of getting amplified further during the pandemic. And so one of the things we wondered, and this was a study that we developed in very close collaboration with Emma Cox at Endometriosis UK, was what was the impact of the COVID-19 pandemic on people with endometriosis. And the study that we ran was a global online survey study. It was in fact only meant to be in the UK, but as soon as we started advertising it, so many support groups from around the world started asking whether we could include their countries that we expanded it quite rapidly. So it was live for a 4-week period, and many of you may have completed the survey. We had it in 5 languages, so English, French, Spanish, Portuguese, and German. So obviously that covered the majority of the major European languages, but also stretched out into quite a lot of Latin America as well. We advertised it really widely on social media, and particularly from support groups around the world, and overall had over 7,000 respondents. Now, our inclusion criteria were reasonably strict. We wanted people 18 years or older who had a confirmed diagnosis of endometriosis, so either by imaging or by surgery. So we narrowed that down to about 6,700 who were suitable for inclusion in the study going forwards. And the data I'm going to show you today is just from the UK study, but we still had over 2,000 people from the UK who completed the survey. So the first question we asked was, has the pandemic altered the availability of treatments for endometriosis? And actually, we were surprised with this data. 60% almost said there was no impact at all on the availability of their current treatments. And the biggest issue was getting hold of repeat prescriptions. So about a quarter of respondents found that challenging, but only 8% had to change their painkillers and 6% changed their hormone treatments, and even less had to actually stop treatments altogether. But the impact was much greater when we looked at planned treatments. So 51% had cancelled or postponed appointments with gynaecologists. 45% had cancelled or postponed procedures, and that was either planned surgeries or planned fertility treatments. And 16% reported cancelled or postponed GP appointments. And then we asked what had been the impact of COVID on symptoms. Now, remember, we were asking this beginning of May to beginning of June, and the first lockdown in the UK started on the 23rd of March. So again, we were really quite early into the pandemic. And we asked, compared to 6 months ago, how would you describe what had happened to your endometriosis-associated pain since the pandemic was announced? And over half, so 53%, said they'd had a marked worsening. So we had a scale from no change to mild worsening, moderate worsening, severe worsening, and the same with improvement. And so the moderate or severe was what we would consider as a marked worsening. And when we looked at tiredness and fatigue, even more described a marked worsening of their symptoms. And again, 3% described a marked improvement. Similarly, we looked at bleeding pattern, and almost half, so 47%, reported a change in bleeding pattern. And if you look at the graph that's there in front of you, you can see that there were a variety of different bleeding patterns that were reported, but most of them included an increase in bleeding. So you didn't have bleeding before, but you have irregular bleeding now. You had irregular bleeding before, but it's got more frequent, or you've got new unexpected bleeding. And then a few described late periods and less irregular bleeding. And how has the pandemic altered mental health? Well, again, almost half described a marked worsening, but 3% a marked improvement. So in summary, this data suggests that 88% reported an impact on their current or their planned treatments. So that's a really significant proportion. And in the majority, pain, fatigue, and mental health got worse, between 47 and 63%. But it's interesting, isn't it, that 3% improved. And another interesting finding was that almost half described a change in their bleeding pattern. And we really hadn't expected the data to be so great. From what we're hearing in clinics and sort of chat around is that actually there's been a real significant change in bleeding patterns for women in general throughout the pandemic. So we don't know with our data set whether that's the patients who had changed their hormones, but actually not very many were describing that. Whether it's stress related, so we know that severe or prolonged stress can alter your menstrual cycle, or whether it's weight related, because we know that a gain of weight and also a loss of weight can disrupt cycles as well. And certainly lots of people sort of 2 or 3 months in were describing a sort of COVID-10, a 10-kilo weight gain from being stuck at home and not doing their normal things. So that may well have had an impact too. And then we thought, well, what can we do to improve things? Because we didn't know how long the pandemic was going to continue at that point. And I don't think any of us were expecting that we would still be going now. And so we asked, what could we do during the pandemic and then as we came out of it? And we asked you to prioritize what would be the one thing that was most helpful with regards to your endometriosis whilst the pandemic continued. And perhaps unsurprisingly, a third of people wanted contact with their gynaecologist. A quarter acknowledged that it was fine that procedures had been cancelled, but they'd like to know when they were going to be rearranged, so they'd have some ability to plan. But almost a fifth asked for support with their mental health. And given that mental health support is not in any of the guidelines currently for the management of endometriosis, I think that's really telling. Much less said that they wanted help with availability of medications or appointments with their GP. And then as restrictions begin to ease, again, what one thing should be prioritised with regards to endometriosis? And in the UK, the data was very clear. Over half of you wanted procedures arranged. A third wanted appointments with gynaecologists, but still another 10% were asking for support with their mental health. And if we look at the worldwide data, actually the priorities were remarkably similar. So the top three in every region, so we divided our data set into Europe, Oceania, which was Australia and New Zealand, North America, which included Canada, and Latin America and the Caribbean. And the top three were the same in each of those regions. Now, they were slightly variable which one was prioritized, but you can see across the world, mental health support is really high on our priority list. So our promise to you is we will do our best to disseminate this information as widely as possible to help women during the pandemic, whilst sadly it's still continuing, and also as we begin to come out. And there's been so much data recently on mental health in endometriosis with the All Parliamentary Support Inquiry and the BBC study a year or so ago. So let's hope that we can just add to this to get some support for mental health as well as our standard management. And one other question we asked was, do people worry that endometriosis makes them more vulnerable to COVID-19? And we were really surprised with the data for this. So over half, 55% said yes, they were worried about this. And actually, to date, there is no evidence that endometriosis increases vulnerability to COVID-19. So it's not something that you should be worrying about, but it's something that we clearly aren't doing a good enough job to get the message out about. So that was the data from that study. We need to step back a little bit to think about what causes pain in association with endometriosis. So this is our traditional view of pain mechanisms in endometriosis. And we used to think that the only way that you generated pain was by those lesions in your pelvis doing something. So either compressing nerves, infiltrating tissues, or causing inflammation. But it was all about those lesions, and that somehow that would send signals up to the brain and generate a sensation of pain. What we know now is that there's almost no relationship between the amount of disease or the location of disease and the pain that you experience. And there's also a really limited relationship between the amount of inflammation and pain. It may be slightly stronger for the relationship between inflammation and period pain, however. And we know that many different factors can contribute to pelvic pain. So this is a diagram just showing that, yes, endometriosis has a role. You can see that here. But all these other factors contribute too, and I'll talk through some of these. And it's important to see that the endometriosis is no bigger than any of the other bubbles around this circle. So in some women, endometriosis may be the strongest driver, but in others it may be playing a very small part, and all these other factors play in. And what's important to think about is the fact that all of these things interact with each other as well. So we tend to think not just about addressing one, but addressing multiple points around this circle. So the role of the central or the nervous system in general, and I think thinking about the nervous system can be quite complicated, but we can break it down into the peripheral nervous system, the nerves from the spinal cord out of the body, and the central nervous system, the brain, the brainstem, and the spinal cord. And if we just think about the central nervous system, one of the things we see in people who have pain for a long time is that they have what we would call sensitization. So it's a bit like turning up the volume on their pain. And so something that used to be just mildly painful becomes moderately or severely painful. And then you're aware of that sensation much more of the time. What we also know is that nerves can generate pain in themselves, so what we would call a neuropathic pain. And there's been very little work done on this in the context of endometriosis specifically. But this pie chart at the bottom here is a figure from some work done by one of my students, Lydia Coxon. And again, you may well have been involved in this study. It was an online survey, again, hosted by Endometriosis UK, where we used a standard screening questionnaire for neuropathic pain. And actually, you can see that 40% of the respondents to that questionnaire described neuropathic pain, and another 35% had features that would be suggestive of a sort of mixed neuropathic picture. So the nervous system is definitely playing a role. We also know that pelvic organs talk to each other, and this is quite a complex figure that just shows how the organs of your pelvis have received their nerve supply. And so, for example, you can see here that there's a nerve from the bladder that goes directly up into the spinal cord, but that also goes up into another place where it meets with nerves that come from the womb and nerves that come from the bowel, and then some of the outside tissues as well. And so if one component of your pelvis is irritable for some reason, so you're having your period, or you've got a bit of a urine infection, or you've got a bit of diarrhea, then those nerves are all talking to each other, and it has a habit of making everything else irritable too. And so it's important that we think about the pelvis as a whole rather than just thinking about where those endometriosis lesions are. Hormones are also really important, and we tend to think of hormones in the context of the treatments that we deliver without thinking about what else can be happening as your hormones fluctuate across the cycle. We know that endometriosis itself is sensitive to hormones, so it will grow and it will bleed with the cycle. But we also know that just bleeding generally, particularly if you have that related condition, adenomyosis, can really irritate the womb, and then it can flare pain from all sorts of things. We know that using menstrual products, so tampons, pads, can irritate the muscles of the pelvic floor and also the vulval skin, and that can flare pain if you have sensitivity in those areas. We know that the hormones themselves play a role in modulating pain. So there's some quite good evidence that low levels of estrogen can make you vulnerable to pain, for example, and high levels of progesterone may damp pain down. So as those levels change across the cycle, your response to painful stimuli may well be different. And some of the stress hormones that are also circulating around, so things like cortisol, can also alter the volume of pain, so kind of turn up or turn down that pain volume switch. We also know that there's lots and lots of muscles around the pelvis. So you can see sort of abdominal wall muscles, the sort of thing you would be developing to get a six-pack. But we also know that there are hip muscles, hip flexors that come down, pass through the pelvis and attach to the hips. And then there are these transverse muscles that are here, but there's also this sling of muscles, the pelvic floor, that the womb, the bowel, and the bladder sit on. And historically, we've tended to ignore these muscles in the context of pelvic pain. If you went to see somebody about a painful knee, for example, one of the first things that would be looked at would be the muscles, as well as thinking about the joint itself. Yet when you come about pelvic pain, we tend to only think about the things that are going on in the pelvis. And it's also important to remember that the nerves that supply lots of these muscles are the same nerves as are supplying all those other things inside the pelvis. And so again, if the bowel or the bladder or the womb are irritable, they're likely to irritate the muscles that they sit on. But similarly, if the muscles are dysfunctional and causing inflammation and irritation, they could well feed back and irritate the other organs too. And this is some quite old data, but I just thought it might be helpful for you to see. Back in 2016, we looked at the first 100 patients we'd seen in our gynecology pelvic pain clinic and found that 71% of them had a muscle component to their pain. And we looked at how many, if we just looked at those who also had a diagnosis of endometriosis, and it was still 64%. So just because you have one thing going on in your pelvis doesn't mean that you can't have something else. And then we looked at the outcome data when people had finished their course of treatment with the physiotherapist. And as you can see, actually, it doesn't really matter whether you have endometriosis, adenomyosis, or no underlying pathology. Patients were reporting a really good response to physiotherapy. And these are a few slides put together by MRR psychologists to try to describe how some of the other factors that go on in life can impact on pain. So bear with me as I talk through some of these cycles. And the first one is to think about sleep. So we know that pain can impact on your sleep. So if you're in pain, you might start worrying, what if I can't sleep? And then you're lying there trying to get to sleep, or you get woken up and you're trying to get back to sleep. And that feeds a set of thoughts about how am I going to cope with tomorrow? I had something important, or I've got to manage getting my child to school or going to work. And that's going to make it harder for you to get back to sleep and flare that bit of the cycle. And you start to feel stressed, your muscles start to get tense, and then you get physiological arousal. So being sort of ready to deal with things, which obviously makes it much harder to get back to sleep again. And will also all flare your pain, making you worry even more. And you can see it becomes very clearly a vicious circle. On the other hand, if you sleep well, then you have a really good day the next day. Lots of us will then have that thought process, I should make the most of this. I must do everything I possibly can when I've had a good day. And then you increase your activity levels, push yourself, and end up with more pain. And then the following night, that's going to feed that cycle again. If we think about mood, we can see a similar cycle. So you're in pain, but there's something you'd really like to do or that you don't want to say no to. So you'll put a brave face on it and push through. And of course, what do you end up with? More pain. And then you have to have a longer time off to rest and recover. And that makes life a bit miserable, which means that you're not enjoying things anymore and you feel like you're not achieving well. And that's going to drive thoughts such as pain is taking over my life. And that feeds into this feeling of low mood and can probably add in some stressful sensations as well. And then exactly as we talked about at that point in the sleep cycle, that's going to amplify your pain and feed round that circle again. Similarly, we can think about how pain impacts on relationships. So you were supposed to be doing something with a friend, you're in pain, but you don't want to let your friend down. So again, you put on a brave face and push through it. That overactivity leads to an amplification of your pain. And the thoughts that you're going to have will include things like, I'm not good company. My friends always think I'm complaining. They won't invite me again. So what do? You might well think, well, actually, I'm not going to make plans in future in case the pain gets in the way of those. And then you withdraw. That makes you feel isolated and lonely, decreases your mood, which again amplifies your pain. So hopefully you can see from these cycles that the relationship between mood and pain is really complex. And I think, or I hope that everybody has moved away from that old-fashioned view of thinking that people with chronic pain have chronic pain because their mood is low. Actually, we know that it's a bi-directional relationship. You're going to feel miserable and anxious living with pain and not knowing what's causing it. But also, if you do feel miserable or anxious, that's going to amplify your pain and worsen these cycles. So, how can we think about managing endometriosis-associated pain? And as I say, this is specifically talking about the COVID times, but I hope lots of it will also feel relevant for you moving beyond this. So the first thing to say is if your surgery has been cancelled or postponed, which we know was the case for an awful lot of people back in March, April, May, and that waiting lists have really not got back on top of themselves and everybody's worried about whether that's about to start to happen again. I think it's really important that you think about what that means. So the first thing to say is that we have no evidence that endometriosis is a progressive condition. So just because we don't treat it now, doesn't mean that in 6 months or a year or 2 years down the line, you'll now have much more severe endometriosis. And what we also know is that actually the first line treatment can be either medical or surgical, and there's no evidence that one is more beneficial than the other. So there's not a reason to think that your condition will worsen if you don't have an operation now. That doesn't mean that it's not causing you concern, but that from a biological reason, we shouldn't worry about it. And I think we can always try to take the positives out of these things. And so you can use this as an opportunity, albeit not a wanted opportunity, to explore any of the non-surgical options. And we certainly know that people who go into an operation for any reason with a background level of pain are more likely to develop a new post-operative pain as well. So the lower your pain levels are before your operation, the less likely that is to happen. And we've talked a little bit about all those different components that fit around the vicious circle of pain. And the more of those bits of the cycle that can be addressed, the lower your pain might be before you go into the operation, but also the more of the pain that remains will be endometriosis driven, and therefore you'll see much more benefit from the surgery when it happens. We think about hormones, as I said, in a lot of different ways. And I think one of the things that we very strongly recommend in our clinic is that we should aim not to be having a period or any bleeding at all. And there are a number of reasons for that. But one of the key reasons, as I said, is just that any form of bleeding tends to flare pain and irritate tissues, and therefore make it much harder to see benefit. We also know that there are some theories for how endometriosis develops with retrograde menstruation, so bleeding backwards from the tubes into the pelvis. And therefore, if you're not having any periods or bleeding, hopefully there's nothing that causes the disease to continue to grow. And we were surprised to see that actually most people seem able to continue their hormone treatments throughout the pandemic. So only 6% had to change and 5% stop hormone treatments altogether in our study. And therefore, hopefully that will be the same as things go on. If people do tell you that you need to stop or change your hormones, so you can't have an injectable hormone, for example, then you need to fight for those. And some people were certainly being told about, for example, the Depo-Provera, the injectable progesterones. It's just a contraceptive, so switch onto a mini pill just for the time of the pandemic. And that might be fine if the only reason you're using that treatment is to provide contraception. But if you need that higher dose of progesterone to keep your endometriosis under control, then that wasn't an adequate alternative. So I think it's really important to emphasize to GPs or pharmacists or family planning clinics that actually this is a medical treatment. It's not just contraception, and you can't chop and change. Painkillers. We know that people tend to get better pain relief if they stay on top of their pain rather than waiting for their pain to get on top of them and then trying to fight an uphill battle. And a regular dosing of paracetamol and an anti-inflammatory such as ibuprofen or mefenamic acid, Ponstan, Voltarol can actually be really helpful. And the way we tend to recommend you take it, unless you have a reason why you can't take one of these drugs, would be to stagger them out throughout the day. So when you wake up in the morning, you have your paracetamol, a couple of hours later, you have some ibuprofen, 2 hours later, you have paracetamol, and so on through the day. And if you take the formulations where you can have 4 paracetamol a day and 3 non-steroidals, then you're kind of splitting it out quite nicely across the day. Now, obviously, if your pain decreases, you shouldn't keep in the habit of taking it every day. But certainly if you're feeling like it's going up or you're going to need pain relief, that's how we would recommend taking it. And back sort of April, May time, there were quite significant concerns as to whether non-steroidal drugs such as ibuprofen actually worsened the symptoms of COVID if you got COVID. But actually, we know that that's not true now. So there's no reason why you can't take a non-steroidal, even if you have some cough or temperature or anything like that. We also know that it's really important to limit the use of opiates. So morphine, tramadol, codeine, cocodamol, all those kind of drugs. Obviously, if you need them to get through a flare, we're not saying don't take them, but they do have side effects. And one of the predominant ones is that they cause constipation. And once you're constipated, your bowel is irritated, it's heavy, it sits on your pelvic floor, which is having to work harder to hold it up, so it gets tighter and sorer, and it can tend to flare a bit of a cycle in itself. We also know that in about 20 to 25% of the population, opiates can actually make you more sensitive to pain, so turn up that volume switch once you take them away, and that's something called opioid-induced hyperalgesia. And so, though at the time they might feel beneficial, when you stop taking them, then you're going to amplify your sensitivity to pain in general. And we know that women more than men are sensitive to developing that. And obviously, we know that opiates are addictive, and so they can be hard to get off once you've got started on them. And as I said, we did see about 40% of women in our survey study who described features which would be consistent with neuropathic pain. And there are specific drugs such as amitriptyline, gabapentin, duloxetine, which treat neuropathic pain and are commonly used for post-herpes pain or diabetes, neuropathic pain, for example. We just have never tested them in the context of endometriosis. But if you're in the middle of a pandemic, you can't access your surgery or your standard treatments, and you feel like your symptoms are very much neuropathic, then it might well be worth talking to your GP about them. And GPs are really familiar with these drugs because they use them all the time for neuropathic pain. We've talked a bit about how bowels and bladders talk to the rest of your pelvis, and I think it can be really important to remember to look after your bowel and bladder, and they're sometimes the things that slip when the rest of life takes over. So if you feel your symptoms have really got worse, maybe think about your diet, and has that changed at all since COVID-19? Are you having enough fibre? So were you able to get wholemeal bread or fruit and vegetables, or actually you having too much fibre? Have you gone back to real basics cooking and you're making lots of beans and lentils and things like that? And both of those things, not enough or too much fibre, can flare symptoms. And if you feel that your food might be relevant, it's often worth keeping a diary, and keeping a diary of what you eat throughout the day, but also what your stools are like, and see if you can relate that to your pain at all. It's also worth thinking about fluid intake. So are you drinking enough? Lots of people found that when they couldn't pop out to the coffee shop and things like that, they were actually really restricting what they drank, whereas others were thinking, well, I'm at home all the time and I can just continuously go to the kitchen and get a drink. If you're dehydrated, that can cause constipation, but it can also cause bladder irritation because the urine in the bladder is much stronger than it normally is, and then that irritates the tissues around it. And we also know that there are certain drinks that will be specific bladder irritants. So blackcurrant is a real problem, particularly with little kids. We often see that if you drink too much Ribena, they get real bladder symptoms, and just cutting out that blackcurrant can be enough. But lots of adults will drink lots of that kind of squash as well. Alcohol is very irritating to certain people. For some people, it won't cause any symptoms, but for others, it can be really irritating to the bladder, and so can caffeine. And we certainly know that the population as a whole increased both their wine and their coffee consumption since the pandemic started. If you do have predominant bladder symptoms, particularly if you get recurrent symptoms that feel like you have a urine infection, it might be worth getting hold of some D-mannose. This is a sugar, and you can buy it from Holland & Barrett's, Amazon, wherever you want to get it from. It's not a licensed drug, but it's been shown to be very beneficial at preventing recurrent urine infections. And can you reduce your anxiety or your stress levels? So we know that particularly the bowel has a really close link to the brain, and if you're anxious or you're stressed, your bowels will play up. And lots of people will remember that from interviews or exams where they want to be able to concentrate and yet they keep needing to rush to the toilet. So maybe some of the strategies we talk about later, reducing anxiety and stress, might be helpful for bowel function as well. We also know that exercise is really beneficial. So it's good for your physical health, but it's also good for your mental health. And ideally, that should be exercise outside every day, trying to get some fresh air and just have a break from that home environment. But for not everybody is able to get outside, not everybody is able to get a bit of time to themselves to do that. So there are plenty of exercises you can do inside as well, even if you don't have any equipment. And certainly yoga and Pilates are really good pelvic friendly exercises. And we also prepared an exercise program leaflet that was on the Endometriosis UK website, and I hope still is. That was prepared by our physiotherapists. One of the things that I think it can be really helpful to think about, particularly if you're doing things like yoga, Pilates, or our exercise program, is actually, do you find it quite hard to focus on whether your pelvis, your lower abdomen, is doing what you want it to do? And we certainly know that people who've lived with pelvic pain for a very long time start to stop paying attention to their pelvis because it's an area that's causing them trouble, but also because you need to ignore it to get on with your life. And actually trying to re-engage with it and think, am I engaging the muscles that this Pilates exercise needs me to do, can be really quite challenging because you have to focus on something that you don't like thinking about. And we've talked about mental health a few times already. It's really important to look after emotional well-being. And I think that generally, if we look at the population, lots of us feel a sense of threat at the moment. And those threats can come from a variety of different things. And if you already have concerns about your endometriosis or your pain, that's an additional bit of threat on top of the other things going on. COVID, American elections, Brexit, all of those things might feel threatening to you at the moment. And we know that when we feel threatened, we have a variety of different responses to that. So we have some thoughts, things like, I can't cope, there's nothing I can do, things are out of control, what if this happens? And our body will respond to that threat. You will have a racing heart, your body's getting ready to run. You can feel that heartbeat, your muscles tense, ready to go. That can lead to stomach aches. You can be tearful and have poor concentration, and obviously, as we all know, have pain. Your emotional response will be quite variable, but you might find that you feel stressed or worried or irritable. Or on the other hand, you might just feel quite disconnected and numb from everything that's going on, and that's not normal for you. On the other hand, you could feel sad or angry, be really frustrated with the situation, or actually become very self-critical. And again, in response to that, we will all have a variety of different behaviors. You might be someone who pushes yourself to do as much as possible as your coping strategy, or you might withdraw into yourself and not do any of the normal things that you would do. You might skip meals, or you might comfort eat, and both of those can have negative outcomes. You might become irritable and snap at other people, or you might stay up late and have difficulty relaxing and lose out on your sleep. And it's really normal that people feel like that at the moment, and we shouldn't be too critical of ourselves for experiencing those sensations. But what we know is that how we regulate our emotions depends on three different systems in our body. And there's a threat system, a drive system, and a soothe system. And for many people at the moment, for many people who experience chronic pain, even outside of the COVID situation, the threat system will be the most predominant and the soothe system the least. And what we're aiming to do with lots of the work we do with the pain psychologists is to move you towards those three things being of the same size, so that your soothe system comes much more online and your threat system damps right down. So how can we reduce the feelings of threat? Well, the first thing we should do is just limit our exposure to information. And we're all inundated with the news 24 hours a day in a way that we never used to be. You can pick up your phone, you can check on your laptop, you can turn on the radio or the television. There's always news and information about COVID there to hear, or about whatever other things you find threatening. Don't go on social media if the comments on there make you feel upset or threatened. Try and add some other activities into your routine. So if you've planned some exercise, or you've planned to have a coffee with friends, for example, then not all of your time is available for you to be processing those threatening pieces of information. And there's certainly some good evidence now that if you actually acknowledge how you're feeling and name it, even though that sounds quite a minor thing to do, rather than trying to ignore it, just saying, do you know what? I feel really anxious today, or I'm feeling completely out of control and overwhelmed, that actually that can help you deal with it, because you've actually said, I know what it is that's happening. And lots of people will talk about keeping a diary or journaling as a way of getting through some of these challenging times. And how can we upregulate our soothe system? Well, again, in your routine, you can try to include some pleasurable activities. So think, what is it that I find meaningful? What is it that refills my empty cup? And I'll make sure that I schedule some time to do that every day. Practicing gratitude. Again, this is one of those things, if it's not really your cup of tea, it sounds a bit silly, but if you do it, it really does change your mindset. So the suggestion is that at the end of every day, you think about 10 things that you appreciated that day, or 10 things that you're looking forward to tomorrow. So that could be as simple as the smell of a coffee when you opened a new bag, or the feeling of the sun on your skin when you went out for a walk. It doesn't have to be anything very major, but to try to think about what are the 10 good things that happen. Do something kind for somebody else. That can actually turn on our soothing systems. Look after your body. Think about what you eat, getting enough sleep, having some relaxation, and try to hold a balanced perspective. So again, this isn't saying, oh, you've just got to be positive about everything. It's just thinking, well, what are my negatives and how could I rebalance that a little bit? So I can't control what's going on at the moment. I couldn't control the American election. I can't control the increase in COVID rates, but I can look after myself and I can make sure that I am as robust and as resilient as I possibly can be to deal with these threats. And something that I think lots of us find really challenging is to learn to accept uncertainty. So we don't know what's going to happen, and that is what it is, and we have to find a way to get through that. Sleep is really important, and we know that poor sleep makes it difficult to cope with things that you would normally cope all right with, and that poor sleep can amplify pain. So you only need to deprive a completely healthy person of one night's sleep to make them as sensitive to a painful stimulus as someone who has chronic pain. So fatigue, exhaustion, has a big role to play in amplifying pain and making it difficult for us to deal with it. And lots of people at the moment will say they are sleeping, but their sleep doesn't feel refreshing. It doesn't feel, when they wake up, they're just not feeling as ready to go as they normally would. So even if you're having enough hours of sleep, it's that quality of sleep too. And there are lots of different tips for trying to optimize sleep. One of the things that's definitely recommended is to have a really good sleep routine, so that you do something that you wind down as you get into bed. So you know that doing these things is kind of a signal to your body that you're getting ready for sleeping. Keep your bed for sleep is very definitely what people recommend. And people who struggle with their sleep quite often find this quite irritating. They say, well, my partner always reads in bed and he's fine, he can sleep. But actually, if you're someone whose sleep is disturbed, then your mind and your body need to know bed is for sleep. It's not for reading. It's not for watching telly. It's not for playing on my phone. It's a sleep environment. Going to bed at the same time and waking up at the same time will sort of help to reset some of the hormone cycles. And so even if you couldn't sleep, you still need to get up at your normal time in the morning, rather than saying, well, I didn't get to sleep till 3, so I'm going to lie in till 11, and then your body clock pushes that further and further around. And if at all possible, trying to avoid napping during the day, as that then makes it harder to get back to sleep the following night and kind of feeds into a vicious cycle. We all know that we should avoid things like coffee in the sort of 4 to 6 hours before bedtime, but lots of other drinks will have caffeine in them as well. So does chocolate. So just thinking, what are the things that stop me being able to sleep in my diet? And this balance between natural light and blue light, we need as much daylight as possible to keep our body clock synced with what's going on. And so trying to get outside during the day and sort of seeing some natural sunlight, but then avoiding blue light as much as possible in the sort of 2 to 4 hours before bedtime. So televisions are fine because they don't emit blue light, but screens, computer screens, phone screens, tablet screens will all emit a blue light that tricks your mind into thinking that it's still daylight and makes it harder to get to sleep. And learning some tips from things like relaxation programs, mindfulness exercises can be really helpful for once you get into bed trying to switch off and go to sleep. Lots of people will do a body scan where they count up follow up from their toes upwards until they fall asleep, or the other way around. Others will do really boring exercises, counting sheep or counting backwards in sevens, those kind of things. But something that's going to tell your mind that now's the time I'm dropping off. And then the final thing I wanted to talk about is just a little bit about activities and relationships, because lots of our normal day-to-day lives changed so much early on in the pandemic and are looking like they're changing again at the moment. And so it might be worth thinking, if your pain has worsened, or if you're the lucky 3% whose pain's got better, what has changed in your life? And did that help or worsen the situation? So things you might want to think about are you moving more or are you moving less? So if you had a desk job before and you were furloughed, have you been doing loads of housework and going out for runs and bike rides and so on? On the other hand, if you were really active and now you're just sat at a desk job or sitting on the sofa watching telly, actually, are you moving less, and is that worsening your pain? Do you have nothing to do and therefore you're spending lots of time actually doing some pleasurable relaxation? Or has your time been so filled with work and children and other stresses and jobs that actually you have no time for yourself and no relaxation? Lots of people found that interacting less with their family or work colleagues was a positive thing, but not getting the chance to properly interact with friends takes its toll. But for others, spending time with a close family 24/7 might be very, very trying. And actually, it's worth thinking about that and seeing whether there are changes you can make. And one of the things we just wanted to mention at the end was to think about pacing. So activity is important, but if activity flares your pain, then that's going to set you back. So that red boom and bust cycle where you have a good day, you do lots, then you have a really bad day the next day, and keeping on going like that can be really challenging, and flare management is often quite hard to get on top of. Whereas if you just increase your exercise level or your activity level gradually up into the limit that you know is your limit, then actually if you have a good day today, but you only do that much, then you can do some relaxation and enjoy feeling better. Then the next day you might have another good day, and very gradually that positive continues to increase. And these are just a few resources that I thought might be helpful if you weren't aware of them. This book, I think, is really excellent. It's written by a GP, and it gives you almost a menu of things that you can look at to try to reduce your general stress. And not all of it is going to appeal to you, but there's bound to be one or two things you think, do you know what? I can just add that into 5 minutes in my daily routine. And overall, you might well find that it's beneficial. Sleepio is an online CBT-based sleep program, and it's free for some people. Other people have to pay, but certainly have a look on it and see whether it is free for you or whether your GP can refer you for it. It's a sort of 6-week, I think, program where you keep sleep diaries and you gradually build up some of the exercises that you're doing, and it's a very evidence-based program. And so if you're not able to access help from someone else with your sleep, you might find working through that. Our physiotherapists really recommend Yoga with Adrienne, who, as you can see, has over 8 million subscribers. But this is a really gentle, easy to access yoga program that's very safe. And if you're keen on Pilates, the Australian Physiotherapy and Pilates Institute, the APPI, do offer a set of courses. Some of them cost, but there are some free resources on their website as well. And again, those are very safe exercises that you might find are helpful. On the other hand, as I said, we wrote some resources at the beginning of the first lockdown that were available on the Endometriosis UK website, including some exercise programs. And if mindfulness is your thing, then Headspace and Calm are 2 apps that come recommended by our psychologists. And again, There are things that you can try, a free 30-day trial, see whether it's your cup of tea. And lots of them were offering prolonged free components to them throughout COVID. So in conclusion, I think it's probably unsurprising that COVID-19 has had a huge impact on care and symptoms for people with endometriosis in the UK. We've seen, again, as with all the other things that have come out recently, that mental health support is really important, and we will do our best to persuade people that that needs to be a priority. But there are lots of medical and self-management options available, even if you can't access surgery at the moment. And as I mentioned, the skills that you've learned now doing some of these things might well help to prevent and reduce flares in the future, even long after COVID is finished. So just a few acknowledgements. Licia here did almost all of the analysis of the COVID study, and that was designed in collaboration with this team of people. And Lydia is one of my students who's done the work on neuropathic pain. And this is our clinical team from our chronic pelvic pain clinic and our endometriosis associated pain clinic in Oxford. Emma, our psychologist, did lots of the work on preparing some of these slides and the resources that are available on the website. And Sophie, her student, also worked with her on those. And our 3 physiotherapists, led by Katie Gore, who didn't have a picture available, but Alice and Olivia, who also worked really closely with us. Thank you. I think there are some questions.
Thank you so much, Katie. That was really, really informative. I found the pacing and the sort of pain cycles really, really interesting. That definitely fits in with quite a lot of the pain I experience. So thank you very much. So we've got quite a lot of questions that have been written in. So really sorry if we haven't got to the ones asked this evening, but hopefully some of the ones that we've already got will kind of cover some of the later questions as well. So the first question is, someone has written in saying that they're finding fatigue a lot harder to manage than pain at the moment, and they're wondering if you had any advice for that.
And I think that is a real challenge. And I think lots of us think about chronic fatigue and chronic pain as being along a spectrum. So some people will just have pain and some people will just have fatigue. And there will be quite a lot of people in the middle who will have both. And it can sometimes be really disappointing when we manage to get rid of pain, but actually the fatigue persists because your quality of life doesn't feel any better. I think lots of the things that we've talked about a bit already today can be helpful. I think it's worth remembering that fatigue isn't always just tiredness. So sometimes there is something about fatigue about just wanting to be away from the situation. And that's part of that threat being online all the time, that actually our body's way of dealing with it is to say, I just need to be away from it. And so lots of these sort of mindfulness, relaxation, sort of beginning to be a bit more mind and body in touch. So yoga, those kind of things can be really helpful, and things that improve the quality of your sleep rather than necessarily the quantity of your sleep. So if you do things like the Sleepio program, for example, it's quite counterintuitive that the first thing it does is ask you how many hours a night you sleep, because you might have lots of broken sleep. And then it sticks that all together and then tells you, right, you can't go to bed till 3 o'clock tonight. And for the first week, you can only sleep 3 till 7, and it's really hard to stay awake. But then the next week you'll move that forwards till 2, and then 1, and so on. And actually in the end you end up with a full night refreshing sleep, whereas actually you were having a full night with broken sleep and actually ended up feeling much worse. So looking at sleep and looking at just general emotional well-being, I think, are the best things to tackle fatigue. I think if your fatigue is post-COVID, that is probably a different question. And we are certainly seeing that there is a very clear proportion of people having very long COVID symptoms, and fatigue is a big component of that. And I think if that's the case, it's worth seeing your GP and asking what they can recommend and whether there are any teams who have a real interest in that, because there's certainly a big clinical and research area thinking about long COVID and what's going to happen in the longer term if we really continue to see such high proportions of that.
Okay, thank you. So the next question, someone was asking if you could suggest anything they could take for pain apart from ibuprofen and cocodamol.
Yeah, and I think it's very hard to know without knowing your individual situation. So I'm wary about not wanting to give medical advice. But certainly, as I said, if you can take paracetamol, then alternating your paracetamol and your ibuprofen can actually make a big difference. And then you might be able to hold some codeine in reserve rather than feeling like you have to take all of them all the time. But I think looking at your pain and thinking, what are the characteristics of my pain? Is it that real aching, muscly type of pain? In which case, do I need to be thinking about things that would help with muscle heat, relaxation, baths, stretching exercises? Or is it a burning, electric, stabbing type of pain that might be much more nerve related? In which case, it might be worth talking to your GP about whether they would be happy to trial a neuropathic drug. But without, as I say, without sort of seeing and examining, it's hard to give a very clear answer to that.
Okay, amazing. I'd never actually heard of the neuropathic drugs before, so that's very interesting.
As I said, they're not licensed for endometriosis. They're not even explored in the context of endometriosis, but they are drugs that are standard for neuropathic pain and used for other chronic pain conditions like fibromyalgia, which we know has very strong overlaps.
Amazing. So, someone else was wondering whether stress can trigger painful flare-ups.
Yeah, very definitely. And we see it generally day to day. So I work a lot with teenagers, and we certainly see that pain tends to flare towards exam times. And COVID has done exactly the same, I think. And stress can increase your pain in a variety of ways. So if you're stressed, you will tense your muscles, and some people will tense their neck and shoulders and end up with headaches. Some people will tense their pelvic muscles, their lower back, end up with pelvic pain. But also, it will disrupt your sleep. It will make you anxious and feed into pain that way. But also, stress hormones in themselves can amplify pain as well. So there are kind of multiple different layers by which stress impacts.
Okay, amazing. So another question was that someone is wondering what their expectations of pain should be after an operation, and how they can manage this pain if they're not able to get a GP appointment or speak to their consultant.
So I think that's probably a two-part question. We can think about immediately post an operation and more longer term beyond an operation. So in general, I think most of us would only do operations if we thought that it was going to have some benefit on your pain in the end. So we would hope that sort of 2, 3, 4 months down the line, your pain had decreased. But we know that operations are associated with tissue damage. And so there's going to be a flare in pain immediately post-operatively. But that's often a very different type of pain, and it feels all right. It feels like an acute pain because you know it's related to what you've just had done, rather than that sort of ongoing chronic pain that feels much more difficult to rationalize. So some people will have a very strong immediate post-operative pain. And if that's the case, then you need to be contacting back the team that did their operation and making sure that there isn't something that has caused that pain, and making sure you've got adequate pain relief. Anti-inflammatories, again, tend to be the best because inflammation is one of the things that's going on. But for some people, they will be given stronger pain relief as well. I think if your pain doesn't ever really go down, or actually goes up sort of a number of months post surgery, then the operation hasn't necessarily done what it was supposed to do. But there are other reasons why people choose to have surgery. And sometimes it's just about wanting to have an answer to know how much endometriosis is there, whether it's increased or whether it's all settled, or whether you had adhesions. And that's also a perfectly valid reason for having an operation. But if your pain has continued to increase, then I think you need a sort of reassessment, and hopefully you should be able to get in touch with a gynaecologist or a GP at this stage.
Thank you. So the next question, I guess you kind of covered it in your talk, but I will ask it again. So what kind of exercise can you do at home to help with endometriosis pain?
So I think, again, we did sort of go through this, but I think any form of exercise is beneficial. And if you're doing exercises that you find flare your pain, don't do them. But if you find they just make you feel a bit achy, but actually tomorrow you feel a bit better, then that's not a bad thing. So you have to be not scared of pain as a sign of sort of tissue damage, but you don't want it to be anything that really flares your pain badly. So, if going for a walk is a good thing for you, then go for a walk. But actually, if the pressure of that kind of exercise is bad, then things like Pilates and yoga might suit you better. And I think it's quite personal. We've certainly found a lot of people struggling that they can't get in a pool because swimming is a really good form of exercise that works those muscles, but without putting a sort of strain through them. So these things are challenging at the moment, but definitely Pilates and yoga are things that work really well. But trying to get something that gets your heart rate up as well is going to do you some physical good if that's something you can do.
Great, thank you. So somebody else wondered how complementary or alternative therapies can help with pain and which are the most effective.
It's a really good question, and I suspect it's an answer that we will have better answers for in a few years' time. I think at the moment we don't have any really good evidence that anything is beneficial, but there are lots of small studies that look like it might be, or that for one or two people will get really good benefit, even if everybody else doesn't. So I think part of it is just about thinking what fits within your beliefs. What do you feel comfortable doing? What do you want to give a try? Some of the Chinese medicines have harms associated with them. And some of the things like St. John's wort or those kind of over-the-counter tablets can interact with other medications. So just to be aware that not all of the complementary therapies are completely safe. So it's worth just looking into them in a little bit of detail if you're using other medications, for example. But in general, people find a variety of different things might be helpful. So modifying your diet might be helpful. Acupuncture, though I don't think many people are providing that at the moment. Things like osteopathy, chiropractors, definitely people find benefit from, but they're often quite short-lived because they're not getting into they're dealing with the problem now, but not dealing with the underlying cause. So physiotherapy tends to be a longer lasting treatment with regards to that. But yeah, it's a case of what sort of fits within your belief system, but we don't have any generally good evidence for any of it at the moment, but mainly because the good trials haven't been done.
Yeah, hopefully we'll get some more information one day. I'd be interested to know what kind of different therapies are helpful for sure. So kind of leading on from that, someone else was wondering if there's any approaches to diet that could support effective pain management.
And that's also a really good question. And I think a bit like lots of this, that there's probably not a one size fits all. You might read some stuff about endometriosis diets, the same as interstitial cystitis diets and things like that. But I think it tends to be quite personal. And probably the best strategy is to keep a diary to start with of everything that you're eating and drinking and your pain and other things like bowel and bladder symptoms, and to try to see whether you can spot patterns, and remembering that the pattern might be a day or two later rather than on the same day. So things that are commonly problematic will be gluten containing things if you happen to be gluten sensitive, acidic things if you happen to be acid sensitive, alcohol, caffeine, black fruits, but then also orange, lemon, mango can also be a problem, and dairy as well. So those kind of classes. I think one of the things to be really careful about is not to take foods out of your diet completely so that you take out a whole food group. So don't completely exclude dairy without thinking, how are you going to get the calcium and the protein and things that you were getting from dairy? And also to make sure that actually you don't make your quality of life so much worse. So there will be people who say, I have found that if I exclude everything other than these 4 foods, my pain is bearable, but actually my life is so miserable because I can't do anything. I can't go out to eat. I eat boring foods all the time, la, la, la. That actually you have to kind of weigh up the pros and cons.
Yeah, definitely. So the next question was whether different symptoms benefit from different pain management regimes.
As in different types of pain symptoms?
Yeah, I think.
Yes, I think very much so. And I think I've already said, I really don't believe that there's a one size fits all. And I think what we would tend to do is assess everything and then think about, well, what might help with the bleeding related pain? What might help with the bowel related pain? What might help with sex related pain? And are there things that don't fit within your lifestyle, in which case there's no point in us recommending them? And trying to make a real personalized treatment plan. And that's slightly the problem with things like the NICE guidelines, is that they're only evidence based and they will just give you a kind of standard set of things, but that's not going to work for everybody, and it's not going to work for everybody's type of pain. So trying to kind of step back and get an overview.
Yeah, sure. So somebody else was wondering whether you can treat pain from endometriosis while also waiting for operations, but without taking hormonal treatment.
That's a good question. I think there are two things that are challenging in that. So one is that whilst you're not taking a hormone treatment, you're continuing to have those fluctuations and you're continuing to bleed. And therefore, we often find it tends to be 3 steps forward, 2 steps back, because you get a bit better and then you have a bleed and it flares everything and it makes everything inflamed and sore and whatever. And then you have to sort of start a bit further back. And so it's hard to sort of continue to improve, and you have to accept that there will be cyclical flares, I think, if you don't want to take hormones. And then the other thing is that it's often quite hard when you're waiting for an operation, because it feels like that's the thing that's going to solve it. And so trying to do the other things in the meantime can be quite challenging. So we tend to say to people that it tends to be better to think, I'm going to put the operation on hold and look at all the other bits, or I'm going to do the operation and then think about the other bits afterwards. And so that's why I guess I was saying that actually, though it's a really bad thing that so many operations have been delayed, if we try and sort of think about changing our mindsets and finding some positivity in something, we could at least use this time currently to address all the other bits, because actually surgery is not an option right now. Then you don't have to be looking forward to it. You can think about, what else can I do right now? But definitely we do see that, if you do the exercises, your pelvis will be stronger and you'll recover quicker from the operation, for example. But as I say, psychologically, it can be quite hard when you're waiting for something which you think is going to be the answer.
Yeah, definitely. So somebody else was wondering if there's any side effects of having a hysterectomy.
Yes. So a hysterectomy is fairly major surgery, and it certainly wouldn't be our first line recommendation surgically by any means. And I think from my point of view, I think that you have to be very certain that the hysterectomy is going to be the solution before going down that route, because it's not reversible. You can't come back from it. Now, if you have very heavy bleeding that really impacts on your life, very clearly cyclical pain, and you're 45 and you've completed your family, then that's a very different conversation from someone whose pain is actually there all the time, doesn't really seem to respond to their bleeding or anything else, and is 25 and has no children. So the sort of conversations we have will be very different. The main side effects are surgical risk. So when you do a hysterectomy, there's a risk of injury to nearby structures, for example. And then there are also the risks, if you take your ovaries away, then you have a premature menopause. And even if you leave the ovaries behind, then there's a risk that the blood supply to the ovaries is damaged a bit, so your menopause will come earlier. And then you have all the risks associated with that of, things like osteoporosis and heart disease and that kind of thing, unless you add in some HRT. So it tends, again, to be a fairly individualized conversation, but it certainly wouldn't be my recommendation, particularly not just for pure endometriosis pain.
Okay, thank you. So somebody else is wondering whether endometriosis pain can be triggered by tamoxifen medication.
So pain definitely can. So I think it depends a little bit what you think about as endometriosis associated pain, if you see what I mean. But we know that dropping your estrogen levels down very low makes you pain vulnerable. And so maybe if you had endometriosis there, but actually managed not to ever have any pain from it up until the point you started on tamoxifen, that could just be the additional trigger for making those pain systems become live. On the other hand, the reason why you're taking the tamoxifen may well have other associated things with it, which are contributing to amplify the pain.
Okay, great, thank you. So the next question is, why does it take so long to get a diagnosis of the type and stage of endometriosis? And why isn't there better information about the different types of endometriosis, such as deep tissue?
That's a good question. And we spend a lot of time talking about diagnostic delay in the context of endometriosis. And I mean, I think I should probably first put my hand up to say that I think obviously diagnostic delay is a problem, but I care even more about treatment delay, because actually, if when you went to the GP with painful periods as a teenager, or the first time you had sex or whatever, someone took you seriously and treated it, then actually maybe the length of time it took to get a diagnosis wouldn't feel quite so unbearable. I think one of the reasons why we have a diagnostic delay is actually the symptoms are quite vague. So we know that you can take a whole batch of symptoms associated with endometriosis, and actually there's no one thing or one cluster of things you can pull out that says, these are the people that will have endometriosis and these are the people that won't. And we have to sort of weigh up the problems with diagnostic delay with the risks of doing lots and lots of surgery in people who actually turn out not to have something that's treatable surgically. So it's a complicated balance. And at the moment, we don't have a non-invasive diagnostic test. So, if you have a big endometrioma on your ovary, that's fine. We can pick that up with an MRI scan. But if you just have peritoneal disease, we don't have any way of diagnosing that without doing surgery. Why is there no information or little information about different types of endometriosis? I don't really know the answer to that. So I think, there is increasing amounts of information available on support group websites, for example, and on different clinicians' websites and things. But I think we haven't fully got to the bottom of how these different types of endometriosis are generated and what is different between them. And I guess, therefore, summarizing it into useful information for people, it is challenging.
Yeah, thank you. So the next question is, can adhesions caused by endometriosis and many surgeries get worse over time and cause more pain? And also whether more surgery would cause more problems?
Adhesions is an interesting question. So adhesions are scar tissue, and they can be caused by the endometriosis itself, or by the operation that happened, or by other things. So pelvic infections, appendicitis, those kind of things. And a bit like when we say endometriosis, actually we don't mean one thing, we mean a range of things. When we say adhesions, it's a bit the same. So some types of adhesions almost look like cling film, and you can just pull them apart, 2 blunt sticks, pull them apart, separate beautifully. Whereas others are so dense and thick that everything is really stuck together and you'd have no way of separating them. So just to call both of those adhesions and wonder whether they're related to pain, you can see why it becomes a bit complicated. So the few studies that have really looked at this properly suggest that those filmy, cling film-like adhesions don't really have any relationship with pain. But the adhesions that cause pain are the very thick ones with a nerve supply within the adhesions, or the ones that are actually distorting the pelvis. So, if they make your bowel have a kink in it that makes it really hard to pass stool along it, that might well cause symptoms. Or if it sticks your ovary down against the side wall of your pelvis, and then every month when you ovulate, it's stretching those adhesions, then that's likely to cause pain. But adhesions per se may not necessarily. Do adhesions progress? I guess if there is continued inflammation there, if you have 2 inflammatory surfaces next to each other, then they can stick together and cause an adhesion. But otherwise, it's probably more likely that you would develop new adhesions if you had another surgery, or if you had a ruptured cyst or an infection or something like that.
Great, thank you. So somebody else wondered whether you're more risk of endometriosis endometrial cancer if you choose not to take hormonal medication or to have surgery?
So, endometrial cancer risk is not associated with having endometriosis. So, having endometriosis does not increase your risk of womb cancer. It does very slightly increase your risk of a specific type of ovarian cancer, but that's probably a different question. So, it's not the endometriosis per se that would increase your risk. The risk factors for endometrial cancer are things like being very overweight, early onset of periods, late menopause, and not having been pregnant. So, the more cycles that you have. So, not using any form of hormonal therapy within that would increase your risk, particularly if, for example, you have fairly irregular cycles. So, you have quite a lot of estrogen going around without having periods to shed the lining of your womb. But that risk is no higher if you have endometriosis than for anybody around who doesn't. If you mean surgery, as in surgery to treat the endometriosis itself, that's not going to make any difference to your risk of endometrial cancer, whether you have surgery or not. If you had a hysterectomy, obviously you take away all your endometrium, and therefore that does remove your risk. But obviously that's a fairly dramatic thing to do just to reduce that risk in the longer term.
Okay, great. Thank you. So somebody else was wondering whether CBD is effective for pain and whether it can be taken alongside other treatment.
Hmm. So that is a really interesting question. And there is definitely some good scientific rationale why any of the cannabinoids would be beneficial both for pain and for moderating amounts of endometriosis. And there's certainly ongoing research looking at that. And certainly in other countries, CBD preparations are available, medicinal cannabis and those type of preparations are available as pain relief, but they're certainly not in the UK. And certainly we do have patients that we know will obtain cannabis as a pain relief and will say that it works, but obviously it's not something that we can recommend. CBD oil, I haven't seen convincing evidence for, but again, lots of people will say that they get benefit from it. And as long as you're getting it from a reputable supplier, which does sometimes worry me, some of the versions that are available might have higher concentrations of things than you would like them to have. Can you use it in combination with other medications? I think the biggest worry is that it makes you drowsy. And so if you combine it with any other medications that make you drowsy, so particularly amitriptyline, but also pregabalin, gabapentin can make you quite drowsy, and so can opiates. So I think if you're going to do that, you would do it very gradually, increasing the CBD oil, and not before you had to drive somewhere or something like that, and not if you were looking after children on your own.
Okay, fantastic. So somebody else has asked whether you could share some advice for trying to conceive with severe endometriosis pain.
So I think that is another really challenging time. I think definitely my feeling is that you don't come off hormonal treatments until the point at which you want to conceive. So there's no evidence that any of the standard contraceptives stay in your body for any long time. So we used to say, oh, you need to come off the combined pill 6 months before you want to start trying to get pregnant, to get rid of those hormones out of your body. And actually, that's not true. They come out pretty quickly. Otherwise, there wouldn't be a risk of getting pregnant if you missed a couple of days. So definitely don't keep things as suppressed as possible until the point at which you want to start trying to conceive. And then I think it's about thinking about all the things that you can do to reduce stress, reduce threat, and look after your body as much as possible, because trying to conceive is a really stressful time, and particularly if you're worried that endometriosis is going to impact on that, or if your pain is flaring as you've come off your other treatments. So thinking about, what are my strategies for dealing with stress? How am I going to build some positive things into my life? What kind of exercises can I do to try and keep my pelvis mobile so that sex isn't painful, and all those kind of things. But I think it's a challenging time.
Definitely. Thank you. And somebody else was wondering, they say that the only treatment they find effective is Oromorph, and they wondered if a GP could prescribe this.
Yeah, and as I mentioned, we're not super keen on people being on things like morphine for a long term, but if it's the only thing that works at the moment until other things are built in, then it would be mean to take it away from you. I think it again is a very personal thing, and it depends how much you're using and how long you've been on it and how well the GP knows you and that situation, whether they're happy to prescribe repeat prescriptions.
Great, fantastic. So somebody else wondered whether low-grade fever is a symptom of endometriosis, and also what you could do about it if it is.
It's not. Um, but if you think that endometriosis is associated with inflammation, which we know it is, then there presumably will be some people who have much higher levels of inflammation and whose temperature setting systems are more sensitive to those inflammatory mediators and therefore maybe present with a low grade temperature. But I think you would have to be pretty convinced that you had ruled out absolutely everything else before you blamed endometriosis as the cause of a temperature, because low grade temperatures can be a sign of other things going on. And I think it would be sensible to have a full workup by a GP or a infectious diseases consultant to be 100% sure that there was nothing else going on before saying, oh, it's fine. It's just that I have a weird type of endometriosis that puts my temperature up a bit.
Great, thank you. Somebody else wondered what the best way to get referred to a physical therapist would be, and they said they've had some problems with trying to get referral.
So referral at the moment is particularly challenging because lots of physios weren't seeing anyone face to face for quite a long time, and so sort of building that up again. I think it's important that you see a physiotherapist who has experience in women's health and who has experience with treating pain. So they don't necessarily need to have experience with endometriosis, but experience with pain, so that they're thinking about tight pelvic floors and hip joints and things like that, rather than sort of more general women's health, thinking about saggy pelvic floors and incontinence post childbirth. Lots of the general women's health physios do pregnancy type physiotherapy, pelvic girdle pain, and that kind of thing. And that can be very relevant to the sort of work. So your GP should be able to refer you to a local physiotherapist. Otherwise, there is a group called POGP, pelvic and obstetric and gynecology physiotherapy, something like that. But POGP is the abbreviation, and they have a list of providers around the country. So you would be able to identify somebody local to you and then either see them privately yourself or ask your GP to refer you to the person you've spotted off that list that looks like they might offer what you want.
Great, thank you. So somebody else was wondering, when do you consider intervention for endometriosis? So I think they mean sort of a laparoscopy.
Again, that's very personal. The guidance is that you can either treat empirically, so assume that you have endometriosis and treat it, or that you can do surgery to definitely diagnose it and treat it at the same time. I think, again, it depends very much what people want. My pathway tends to be to make sure that there's nothing obvious on a scan. So if on a standard scan there's a big cyst or something like that, then obviously that involves a conversation that says, actually, do we want to do something about that cyst irrelevant of anything else? But if scans are negative, then I think unless you have a really strong worry about there being endometriosis, so often people will describe their mum or their sister or their aunt having had a really difficult journey and needing to know for themselves that they don't have endometriosis there. But otherwise, my recommendation tends to be, let's do the safe things that might make a big difference first if we find them. So if we find muscular dysfunction or nerve related dysfunction or anything like that, then we'll work on those things and do surgery if they don't work. But other people will do surgery as their first line. So I would say it's very personal, and it's a conversation to have between yourself and your gynecologist about what would be the most sensible pathway for you. But at the moment, surgery is not happening as easily as it was.
Great, thank you. We probably have time for one or two more questions. So somebody else was wondering if you could give some advice on how to manage pain during sex and also bleeding occurring afterwards and how they can address this.
So again, that is a difficult question to give personal recommendations for without hearing a full story and examining, but I can give a few sort of more generic things. Pain with sex can be related to a variety of different things. So we tend, in the context of endometriosis, to think about it as being, is there deep endometriosis on the back wall of the vagina or between the vagina and the bowel? Actually, what we often find when people talk about pain with sex is that they will either have very sensitive skin at the entrance to the vagina, so what we would call hyperalgesia or allodynia, so where just even light touch feels like burning or stabbing. And so if that's the case, then we need to be thinking about either those neuropathic medications or just using lignocaine gel, so a local anesthetic gel that you can use as a lubricant and include that skin at the entrance. On the other hand, other people will have very sensitive pelvic floors that are tight and tense and generate pain. And so that would be sort of 2 centimeters in or so. And that can often refer up to your tummy. So if you feel that pain sort of deep in where you imagine your ovaries are, that's often coming from your pelvic floor. And that responds really well to physiotherapy. For other people, it can be related to endometriosis, and that would obviously be surgery or hormonal suppression, but usually for that deep area there, it's probably better to think about surgery if that's very clearly the thing that's treating it. And then for other people, there will be a psychological component. And again, it's unusual that a psychological component would be the sole cause, but once you've had an experience like that, your body's response is to protect yourself. And therefore, the next time you have sex, you're thinking, is this going to be painful? So you tense your muscles a little bit more. And therefore, that's more likely to be painful. And then that reinforces that cycle. And so we can often find that in order to really make things better, we have to think about both psychological and physical treatments at the same time. Bleeding is a difficult one, and really, if you're having repeated bleeding episodes after sex, you need to be examined by either a GP or a gynaecologist just to make sure that there isn't anything. If you have been examined and everything looks normal, then it's either, I think we do sometimes see it with adenomyosis, that the lining of the womb is a little bit more fragile, and so it does trigger a little bit of bleeding. And sometimes it can be that there's some fragile skin at the entrance to the vagina. It just doesn't stretch quite as well, maybe because it's not having as good a blood supply, for example. And then that can give little tears and bleeding. But I think bleeding on a repeated episode needs examining to make sure that there's nothing serious going on or nothing treatable.
Okay, great. Thank you so much, Katie. I think that's probably all we have time for this evening. But yeah, thank you so much for speaking with us and for answering all of our questions. Yeah, I really appreciate you giving up your time.
No, my pleasure. Thank you for having me.